keep those coming for new people joining. We're chatting these things in. Okay, cool. Chris from Banner says identifying better ways to train and educate staff, including residents, on substance use disorders and mental health. We're all about that, can definitely help with that. Tina Cox from Valley View says help provide Narcan to patients. We're so excited that so many of you are going to start doing that and happy to help wherever we can. Megan from University wants to better incorporate multidisciplinary support for patients with SUD use in pregnancy. Awesome. Britt, any updates on lactation, breastfeeding support, promoting breastfeeding? Cool. We will definitely talk about that specifically in the Learning Collaborative. We're going to touch on in 2022 just further information on guidance regarding breastfeeding and marijuana, which Carly, who is on the call, is a bit of an expert in, so she's going to be our presenter for that. Cool. Well, we will move on, but if you haven't done so, keep chatting those in. And really exciting to reflect back on how far we've come. So these numbers are from March through November of this year, and this is across all of the teams in this collaborative that we have data for. And we're just so proud to show this. Over 7,500 patients screened for depression, almost 7,200 screened for anxiety, 6,000 for substance use disorder, 465 for ACEs. This is amazing work, and we hope you all can really reflect on what an impact you've made by being part of this collaborative. We know it feels like pushing a boulder uphill a lot of the times, and there's calls, there's data, it can feel like a lot, and we really appreciate all your efforts, and also hope that you can feel pride in just how much we've been able to accomplish together. And so this is just March, which is the first month we submitted data through November. The last month you'll submit data for 2021 will be December, of course, and that will be due in January. And at the end of that, we'll be able to put together a really nice, we're planning to put together a really nice year-end summary for you, so you can share it with your leadership and administration and with your broader team to really show the impact you've made by being part of this collaborative. So really excited to show you this. Next, I want to show you our run charts for the collaborative. I'll focus first on substance use disorder, which is the dotted line. As you can see, the average percent screening over time has definitely trended upwards. So we're so excited about that. Definitely same for anxiety, which is the green. Same for depression. There were definitely ups and downs, but overall, it's certainly increased. And then ACEs, as you can see, we of course haven't really focused yet on ACEs in this collaborative, but we're still really excited to see that some of you are starting to take it on a little bit, starting to think about ACEs. So you can see the increase there as well, which we're super excited about. Other amazing work I wanted to highlight, and you'll get these slides afterwards so you can look at the links and whatnot, but just some other great highlights. We did the tool fair in October, where you got to see some of the tools that other teams have put together. So we're really excited to be able to see those things. Like University made amazing videos. So many of you made awesome protocols and workflows, patient handouts. So we're so proud of that, and are really glad that you can be part of this collaborative where we can all sort of steal shamelessly, share seamlessly from one another. The resource database, which again was something Elena had a big part in basically, as you all made your local resource referral documents, compiling all that information so it's in one place, so you can see what all the other teams have put together. So if you have a patient that doesn't live in where your hospital is, you can really look at what other hospitals have put together. We had great feedback on the presentation by lived experience experts to really bring the human side of substance use disorder to this conversation. We're super excited about all of you who are starting to think about or starting Narcan dispensing or prescribing in units. It's super exciting. And then lastly, we had a great experience with having you all connect to peer navigators and regional health connectors so that you can really understand better the local resources in your area and have patients connect to those peer support specialists so that they have someone really to walk hand in hand with as they embark on care. So with that being said, we wanted to have one of the peer navigators who some of your teams were connected to through this collaborative. Just talk a little bit about, what it meant for them to have been connected to the collaborative and what it meant for patients in the community. So if Vanessa is on, I would love to throw it over to her. Okay, I see you. I'll stop sharing my screen so we can see you, Vanessa.
I'm so thankful first to be here. I got to tell you, my computer went down like 3 minutes before the meeting started, and I literally was rushing around trying to find another connection point and could not find what I needed. So it's crazy that I made it right.
We're glad you did. Thanks, Vanessa.
Right at the nick of time. Because I missed some of that, and you just kind of want to know how it's been being a peer working with Valley View, correct?
Yeah, we'd love to hear, like what has been your experience of working with Valley View through this program? What sort of impact do you feel it's made to be able to connect with them?
First off, I got to tell you, I think so. Like when I first started in this position, really connecting with Valley View, I was working with the crisis team, and it was. I just, I feel like this is where some pieces were really missing, is being able to have somebody come in and really meet, the patients where they're at. And so I really feel like being able to have a relationship with that team, and really, I think them being able to really understand that they can utilize my services. We actually had just gotten, we got a really good flow going. And they could reach me, I could reach them when patients would come there, usually because of drugs and alcohol. And, usually when they're there, they've hit a bottom. And so me being a peer, I have lived experience. And so just to meet them at their bottom, spend some time with them and just really give them support in that moment. And then really they understand that, hey, maybe this is something that could work for them, and then making that relationship with the patient. And I was doing that for a year, and I think 2 people out of the whole year, when I came in there and sat down and had a conversation with them, only 2 people said, no, it's okay. I'm not interested in services right now. And so I can't tell you the exact number, because, for a whole year, like 2 or 3 times a week, I would get a referral from the crisis team at Valley View, and I would meet them there. And only 2 out of a whole year. I mean, to me, that says a lot. Because also I know who I'm partnered with. It's a team that loves and cares, and they want to be able to give support to their patients that come in. And so having this in their pocket has been really, I know, a big support for them, but it also allows me just to do what I love. And that is really help somebody start at the bottom and really, just work on trying to get sober. Here recently, in probably the last 2.5, 3 months, I also started working with labor and delivery at Valley View. And it's funny because we want to talk about successes. My first client with the labor and delivery, her and her child, had drugs in their system. And so I started giving her peer support, and she's doing amazing. Like, absolutely, she works hard at what she wants for her and her child, but that relationship that has been formed, somebody that understands where she's coming from, has just really made a big difference, I feel like, in her success. And during the meeting yesterday, that was something she said, is I never had this type of support before. And she had the option to say, okay, now the case is closed. I'm good. I don't need any more support. And she told them, no, I want to keep doing this because this has really helped me. I feel like somebody understands and I can really share with what's going on inside of me that I've never talked about before. So, and that's really what it's about. It's about all of us wrapping around our patients, our clients, and supporting one another in the job that we do.
Yeah. Well, thank you so much. It's awesome to hear that this has been helpful for patients. It's kind of amazing to hear that only 2 have said no, which is really a testament to, the need, but also the great work that you're doing. So yeah, I really think it's clear that having, people in your role that are working with L&D units and hospitals and EDs also, clearly there's such a need and there's such an impact when you can do so.
I'm honored. And that's another piece to this. It's like, I'm honored to be able to be working with the hospitals in labor and delivery and women's health. And the fact is that I just see all the hard work that they're doing, and they have sleepless nights. They are concerned with their patients. And so being able just to be able to support them also, to me, is an honor because, we work hard and we all care. That's why we got into this. We wanted to serve and help our clients or our patients. And so to me, it's really about, none of us can do this alone. None of us, not the hospital, not peer support, not therapists, psychiatrists, police departments, they can't do this alone. Mm-hmm. And so, when you can go in the community, and I know that if I have a client that comes in there, I know they'll call me and say, hey, your client is here, this is worried. They know also if they have somebody and that they're willing to get some help, they can call me and I'll be there instantly. And I think that's a huge piece, because I know everybody, they work hard, they get tired, and when you've got people in the community that are really give each other support in what we're doing as a whole, I think that also says a lot about the success,
Yeah, most definitely. I mean, I know Mick, who's on this call, has basically said that before too, just having the mutual relationship between you all and her staff and the L&D team. Yeah.
I love Mick. I'm like, love Mick. Mick is incredible. And I can't say enough about Mick and labor and delivery, women's health, about Valley View. They always go above and beyond, always. And at the end of the day, I mean, even though their patients or their clients don't realize, that our medical providers want the best for them and their children and their families, they do. And it's because I only know that because I work beside them. I see, that their hearts hurt when, patients are really struggling. So that means a lot to me. It just makes me want to, support them even more.
Well, thank you so much for being here, Vanessa, and for sharing that reflection with all of us. Really happy to have you here, happy to have you in this work and to be sharing, what an impact it can make to have your hospital connect with someone in a peer support role and what it can mean for clients.
Absolutely. Thank you for having me. Sorry that it was so chaotic to get here, but I was
I didn't notice any chaos on my end at all, so no problem.
Thank you.
Thank you, Vanessa.
So if Katie could just start screen sharing again, and thank you again, Vanessa. That was really great to hear. And we're looking forward to having more connections in 2022 as well. But okay, great, you're sharing. So now we're going to talk about our project highlights for the year. And if people could just share out to the group one of their favorite presentations, a lesson learned, a connection they made, anything that really was important or poignant to them from the 2021 Learning Collaborative. We would really love to hear what made the best impression on you. So feel free to share out to the group, or if you can't come off mute, you can chat it in. Mick just chatted in that her connection with Vanessa was so important. We loved all but that missing piece and made such an impact immediately. Yes, Lisa, you can pick two. Only
And
one
feel free to
favorite
come off
thing.
mute if it's easier to.
Yeah, I was going to say it might be too much typing. I'm sorry, but you know, and there were so many when you asked this question. You know, just the learning things this year. I just feel like my mind's been blown by all of it. But I was super happy and encouraged when I threw out an email to my colleagues to see if any of them would join me in receiving some MAT training from the amazing Dr. Klee, and 9 of them did. And that just reinforced to me that if we give people tools, if we give people information, we work with amazing people who really do want to help. And the other one was just getting to walk into a patient's room and, you know, carefully, respectfully ask her about her past with the you know, introduction that I was working with CQC, and we were trying to do better for moms who had ever had substance use disorders. And, you know, as soon as, you know, that was on the table, she and her husband were so honest and open and helpful and informative. And I was just humbled by that experience as well.
Yeah, that's so great to hear those success stories with talking to patients. I know that sometimes having those kind of intimate discussions can be really hard to start, but they're so important to have like you be vulnerable as well to start those conversations, and starting those like respectful spaces so that these topics can come to light. And Amy Dempsey is saying the story from Vic Bella.
Sorry, I can't remember if that was chosen or this one, but it doesn't matter.
It was chosen, but I know some of you also may have attended that fall chosen forum and agree that was a great story.
Yeah. For anyone who hadn't heard that, Vic Bella is from CPR, I believe.
Yeah, Colorado Public Radio.
Yeah, I was like, I don't know, I'm not in Colorado, but he has a session on there talking about his own substance use journey, and how he has kind of used it to empower himself. So if you haven't heard about that, you should check it out. It's very empowering. Is there anyone else who wants to share? I know we don't have too many people from specific hospital teams. I don't think it's a lot of well, there are some phone numbers. I'm not sure who they are, but it was great hearing from people. So Katie, if you want to move on to the next slide.
Yep.
So we're just going to talk a little bit about sustainability. All of you made such great strides this year in screening and as well as your processes in your unit. And we know a lot of you have brought to our attention capacity issues with staffing in the face of COVID. And we just wanted to kind of have an open discussion about things that are coming up in your units and kind of looking forward as to what strategies we can use as a team to combat these issues. And we thought that maybe having a discussion about it from different hospitals, from different populations and rurality could kind of help bring to light maybe some successes or some solutions to these challenges. So if anyone wants to share some challenges they're having or something that they are thinking might be a challenge in 22, we would love to hear that, and people can chat in or speak out as well.
One of the examples we called out, as you can see, is the staffing issues. We know that basically all of you are dealing with staffing issues because all hospitals in the country are dealing with staffing issues. So that is definitely one thing we can talk about if it's something you've experienced, or like a lot of you had traveling nurses, a bunch of staff turnover. So
Nick just chatted in, being short-staffed, finding time to meet and implement new processes. Yeah, definitely. Has anyone thought about ways to manage this, ways to kind of maybe streamline the process so that with turnover or being short-staffed that you're still able to get these screenings done so that we can maintain the level of screening rates that we saw in 2021?
Well, I can tell you that, I had been having the nurses kind of collect the TAPS tool forms in a certain location, but I think what I'm going to start as of now is to recruit the charge nurses to be able to help a little bit with that, since I'm not at the hospital all day. So I'm going to just make a form with like what the patient's name is, have they been screened, has their provider been notified, and then have the charge nurse just kind of hopefully gently remind people every time the patient comes in that, we can document that there. So stay tuned, we shall see.
Oh, that sounds like a good solution. Having someone other than you, Lisa, being in charge of everything. I think that delegation is really important, so that you all can continue to progress as well.
Yeah, and I am a really bad delegator, so yeah, this is a step for me, but
I am too. And Nick just said, we continue to screen, just need time to implement ACEs. Yeah, it's definitely hard, and that's kind of why we wanted to bring this discussion up, so that you can keep that high screening level that you all have, while being able to add in new processes maybe, or while you also may be having these other challenges such as capacity or the changes in nursing staff or whatever it may be. But I really like Lisa's idea of delegation, even though we're both bad at it. Does anyone else have any ways they're thinking of combating these challenges?
one thing I've really liked hearing about, and like Lisa mentioned, and I know Sterling is doing, is looking for super like manual analog solutions. So Sterling, for example, has a binder, and if a patient screens positive, it's like, okay, this is everything you need to do is in this binder. And I definitely think those are a good way of sort of like hardwiring these changes into your processes, because it's not like the knowledge has to live within one person. It can, be a physical binder, or something super simple like that.
Yeah, definitely. I completely agree. Sometimes having things on paper can be really helpful.
And we had another team, and forgive me, I can't recall which team it was, who, when they had new people join, they would have them, I don't know if it was read through a packet or do something, and then that person had to meet with the charge nurse, and basically the charge nurse had to sign off on the fact that they had completed it. And that ensured that any new staff, traveling nurses, etc., as part of their onboarding, got all the information about this project. So as soon as they started delivering bedside care, they knew what to do, why we were doing it, all that jazz. And again, super simple solution, but definitely helps when you have a lot of turnover and new people joining.
Anyone else, maybe not from the hospital teams participating, maybe from EFG or anyone else who has joined the call, have any thoughts on how to combat this challenge of capacity issues in hospitals? Well, if not, we will move on. We just want to make sure that we're supporting you, and that we can have these open conversations about our challenges, so that we can kind of, as a group, brainstorm. So if things come up in the future, we're happy to talk about them. Sometimes a different perspective can really help. I know that hearing different perspectives just for our work internally with CPC/QC can really help us think outside the box as well. So with that, we're going to start moving into 2022.
Yes. So we're excited to share a little bit about what our plans are, and then get a little bit of feedback from you to help us plan. So first of all, we listened to your feedback this year about, we're all short-staffed. It's hard to be on Zoom. Like, I don't blame you for not wanting to spend half a day on Zoom with me, because I wouldn't want to either. So we're trying to shorten everything. So our monthly coaching calls will be shortened to 1 hour. We'll still have a guest speaker on, relevant topics to this collaborative, but we'll also more intentionally dedicate time to team sharing. Of course, the whole point and value of a learning collaborative is this like all teach, all learn model. So we want to be more intentional about facilitating that sharing and discussion. And as part of that, we are going to assign presentation dates in advance for teams. So, we won't deal with the thing of like, oh, who's worked on this, and a team that's worked on it isn't there, so they can't contribute to the discussion. So that is some of the changes that are coming to that. And then our quarterly learning sessions, we're shortening significantly. So we will promise that they won't be more than 2 hours, and we'll try to make them as short as we can. They'll involve more time for team sharing and discussion, fostering communication between hospitals who are maybe like all the rural hospitals or all the more urban hospitals, inpatient settings, outpatient settings. And then additionally, again, because we know that capacity is an issue, right now we've been having, so for example, in October, we had an October coaching call, but then we also had an October learning session. We're not going to do that anymore. So when you have a learning session, that will be the only meeting for the month. So there will only be one like big plenary meeting for this collaborative per month. Of course, you're still welcome to meet with us as a team, in like individual team, one-on-one, as much as you want. But you won't have as many things on your calendar for the plenary sessions. So, what we're thinking in terms of timeline, we will again do our project kickoff in February. And then, and the blue boxes represent these like longer sessions that are learning sessions. And then March, April, the purple circles, I was going to call them balls, purple circles represent those shorter coaching calls. So one thing we wanted to ask you and get your feedback on, we realize that, so we follow the IHI or Institute for Healthcare Improvement, their breakthrough series model. That's why we're always talking about PDSA cycles and monthly coaching calls and quarterly learning sessions. We love the IHA model. It's very effective. However, we also recognize that there's a lot of jargon involved, and especially in the virtual environment, it's very hard to distinguish, well, what is a coaching call versus what is a learning session? And learning happens at every call, and coaching also sort of happens at every call. So what's the difference? So we wanted to get your feedback on, should we be calling these different things? Like, should everything have the same name? And if so, like, how do we communicate that's quarterly, that they're going to be longer? Or do we rename learning sessions to something else and rename monthly coaching calls to something else? Rename just one? Really want to hear like what makes sense to you, so that it's not confusing or overwhelming and you feel like you have a good enough idea of what it is that we're going to be doing. We've heard some ideas that are like maybe shared learning sessions.
I was gonna say, I like that idea. I think if you can change the titles a little bit just to delineate like what is something that we'd be logging on to where the main intent is to learn from. So like a guest lecture where I, like, as a participant, I'd be logging on and the content would be kind of unidirectional, you know, like I'm logging on to this to gain information specifically from someone versus the meetings where it's like it's not centered around one speaker. It's like a whole bunch of people going back and forth. That might be like a group activity day versus a guest lecture.
Like a webinar or
like
something.
That. Yeah, because I feel like that way you would know kind of how much to like prep going into it and also have a good expectation for like what effort level you will be needing to put in when you're looking at your schedule for the day. Like, is this a meeting that I should be prepared to be on camera and be actively talking with a bunch of different people, or is this something where I can attend and just gain relevant information from an expert sort of thing? But I love both of them. I agree though that the coaching calls and the learning sessions, like I personally didn't know the difference. I just kind of show up to everything.
I mean, we actually don't think our guess is that no one knows the difference, and we don't blame anyone for that because why would you? And IHI was not meant to be virtual. So in a non-virtual environment, it's much clearer because coaching calls are virtual and learning sessions in the IHI model are in person and like a full day or 2 full days. So in the virtual realm, it all feels like textureless in a vacuum. Like, I don't know the difference. This is a lot of words. So we feel you.
Maybe like a seminar series versus a active learning series. I don't know.
I like the idea of seminar because it's more like, because there will be a content presentation from like an outside person, but there also will be group discussion and like at least one presentation from a participating team. So I like the idea of a seminar because it's almost like, like a class in college or something. And then maybe something else for learning sessions, like a group activity or group sharing or something.
Yeah, I agree. I like that you're delineating these. So I think that'll make it a lot clearer for everybody.
Right, because we want people to know the learning, like they are different, and the learning sessions might, be 2 hours versus all the coaching calls will just be 1 hour. So
Lisa just chatted in. She said, honestly, I don't have a strong opinion about changing the names. However, if most want to change, learning session could remain the same, or just monthly meeting for the other, or monthly collaboration.
cool. Yeah, there's definitely no right or wrong answer. We just have known this whole time, like we're probably just confusing people.
Yeah, Katie and I are having trouble brainstorming the best names.
And then we looked at like what other states are doing, and a lot of them are doing coaching calls and learning sessions because we all follow the IHI model in perinatal quality collaboratives. But then some are calling learning sessions like plenary sessions. But technically these are all plenary sessions. So we've been really racking our little brains, and we wanted to ask you all, because ultimately it doesn't matter if it makes sense to us. It really only matters if it makes sense to you. Well, we can move on from this topic. Really appreciate the feedback. And okay, so next is another really exciting part of 2022. So, we have heard continually from teams in the collaborative, from expert faculty group, from people outside of all of that, like, oh, well, like, it's really great that we're doing this on L&D, but what about in prenatal care? What about in postpartum care? Just the outpatient OB setting in general, like, if they're not involved, then how is any of this going to work? And we agree. We definitely started with hospitals for a reason, but moving into 2022, would love to start fostering more of that collaboration between outpatient OB clinics. So that being said, what the plan is we would love if you all, your participating hospitals, could invite whatever referring outpatient OB clinics they'll have patients deliver at your hospital. And the idea is they would sort of join along in the collaborative as a team with that hospital that they tend to work with. And essentially, part of the work in 2022 is, of course, continuing to improve and move towards sustainability from what you've been doing in 2021, but also for us to help foster that collaboration between inpatient and outpatient, and really help with the continuity of care. So the clinics would be invited to join all of our calls. We, of course, will provide tools and resources and customize all of the tools and resources we already provide to make sure that they are relevant to outpatient settings and that there are tools specifically for outpatient settings. We would help you sort of figure out, how establish a regular meeting with those clinics to foster that collaboration and discuss project progress. We have sort of recruitment materials available, and basically what we will do is share those recruitment materials with you. And our ask for you is that you think about what outpatient clinics may make sense to invite to sort of join your team, who might be interested. And then, you make the warm introduction, and then we will help ultimately explain what the project is, explain what's in it for them and how it will work. And we can sort of handle those kickoff calls and figuring out if they want to join. And so that is our plan for 2022. And as part of that, we wanted to spend the next minutes basically really brainstorming, having each of you brainstorm with what this might look like for you. So next, we are going to do a worksheet. So Elena put it in the chat. It's a Word document. If you hover over that file, a little text will come up that says click to download. So you'll want to click that, download it to your computer, and then open it. I explain that because it's kind of tricky in Zoom sometimes. So if you're unable to do that, let us know and we can send you just a link where you can open it. But try first to sort of hover over, click to download, and then open it on your computer. We are going to, for those of you who are joining with other members of your team, we're gonna put people in breakout rooms and spend 10 minutes on the first section of this worksheet. So I'll show you what that looks like. Let me stop my share, just so you know. Yep, okay. So this is the worksheet. In the next 10 minutes in breakouts or independently if you're alone and the only person from your team here, we want you to go through questions 1 through 4, and then it tells you, please rejoin the main Zoom group to discuss afterwards. But these are the questions. It's about outpatient integration, and would love for you to sort of think about that, and then we'll discuss a little bit as a group when we come back. Elena, do you want to put people into those rooms?
Yeah, there's a few people who I don't know if they're affiliated with a learning collaborative team. So if you're stuck in the main room, just let me know and I'll put you in a breakout room. But I will send you off.
And we'll let you know when to come back. You'll have 10 minutes to complete the worksheet. The first 4 questions of the worksheet.
I've got a question for you, Katie, just because I'm not in
Yeah.
any of these groups. So I love this. I love this idea of branching out to the smaller clinics who are sending these women or these people to the labor and delivery wards. I think that's an incredible idea. Is there a way to, in the planning of this branching out, is there a way to include some of the midwifery and doula centers that are in the region? I don't know.
Yeah.
I don't know. I'm not super familiar with how independent they are. I know that they can obviously reference out to labor and delivery wards and hospitals in case something goes wrong. However, I definitely think that is a large sink of patients that would be useful to have at least like a contact at these different midwifery centers. And I'm sure they would be interested. I know I do marijuana work, and I know some of the midwifery centers around here say that you have to test negative for all drugs in order to deliver at their clinic, and they include THC in that, which is interesting because there's actually a lot of research showing how midwifery and doula centers have different is a good word for it, I guess, different recommendations when it comes to prenatal behavior and kind of a more like lax approach, especially when it comes to marijuana consumption. So yeah, definitely just like as we're expanding, it's a patient population that would be easy to miss.
Absolutely. Yeah. I mean, we are open to working with basically anyone that is serving birthing people in a clinical capacity or doula capacity as well. So yeah.
Awesome. Yeah, and I would assume that those clinics would have at least a person or two who would be interested in keeping up with what we're doing. It seems like that would be mutually beneficial. Yeah, I don't actually have any contacts at any of these places. I'm sure some of the hospital-based teams do, but
yeah, I love that. Yeah, and I'm glad you mentioned that, because we can be more explicit in our communications about like what we mean when we say outpatient, and mention like it can be birth centers, it can be I don't know, doula centers isn't the right word, but it can be doulas. Yeah. Elena, did you see Megan's chat about needing the worksheet?
Yeah. Yes, I will do that right now.
Okay. I can also just send them the link.
That too.
Here we go.
Teamwork. There's only a few hospital teams on today.
Mm-hmm.
So you know. Oh. What time has the sun been setting in Colorado?
Sometime between 4:30 and 5. I don't know.
The sun just set
Mandy asked,
here.
do we know where there's information on the number of births in the birthing centers? Yes, actually. So CDPHE's vital statistics. If you download like the birth center, or I'm sorry, the birthing data, it includes all hospitals, all birth centers, and home births, and then like other. And basically facilities are on there. I believe if they've had 3 or more births in that facility.
Yeah.
I'm not sure exactly what the time period is, but
do you have the link
yeah.
to that, Mandy? I can send it to you if you don't.
I'm sure I've looked at it. Sorry, I just wasn't chiming in when it's loud in
I'll
here. but-
email it to you right now. Just so
Okay.
you have it.
Yeah, I'm sure it's like lost somewhere, but I've looked at it for sure.
Yeah.
It's fun to look through the spreadsheet though.
Yeah.
And also, just as an anecdote while we're all here, I was going through it and pulling out, basically like removing the birth centers for some reporting purposes, because we only needed to report on hospitals. And it's funny, it's actually very easy to pull out birth centers because their names are so different from hospital names. It's like blooming bellies. Like, I don't know. I found it entertaining, like how easy it was to just be like, that's a birth center. That's a birth center. No shade to blooming bellies. I don't even know if that is the name of one, but they were all like very lovely names.
A very different approach.
Yeah. And like, that's why they exist, right? People want a
Yeah.
different approach. So
It is such a bummer to me that a lot of the hospital-based labor and delivery wards can get such a bad connotation almost. I feel like there's this big push right now among laboring people where they're like, oh, well, I don't need to do it in a hospital because medicine is like I don't need medicine. It's like, I respect that decision, but I also wish that there was a way that we could have comfortable birthing that still has easy access to like skilled professionals, instead of having to try to do like a labor at home and then end up having to call EMTs and then you're in a crash C-section. It's like, I really wish you could have just done that comfortably, but like in a hospital setting. I don't know. It's hard. It's all hard.
Yeah, it's hard. It's hard because it can be just as safe. And like, we definitely respect the wishes of people to deliver where they want to deliver. But of course, like, we want to make sure that hospital births are also super safe so that someone has like full range of choice so that they feel safe anywhere and they can make a choice not based on fear and based on, you know, other considerations. So
no, I totally agree.
Yeah.
I'm gonna bring people back to the main room. It takes 60 seconds. Lisa's already back. I believe everyone's back now, Katie.
Great. So we would love to hear from you. We can start with the first question. What are your team's goals for increasing outpatient coordination in 2022? And you can chat or come off mute. Love to hear more.
It's okay. I'll make some shit up.
Anne and Megan from university. Can you hear us?
Oh, yes, we can hear you. You're a little quiet, but we can hear you. I wasn't sure if you were talking to us or.
We're having all kinds of technical difficulties. So we could see question 1, 2, and 3, so we answered those, but we couldn't see question 4, and our form wasn't able. We weren't able to open the form once we downloaded it. It went into some kind of an error mode.
Oh, okay, good to know.
So our team goals for increasing outpatient coordination in 2022 is to continue to work with our prenatal clinic here at UC Health and just have some more robust communication between inpatient and outpatient for the patients that kind of are red flags in our system. And then our second goal is to try and outreach to our outlying clinics that deliver with us, specifically Stride, Salud, and our 2 family medicine clinics. We want to set up a collaborative meeting with some representatives from all the teams and make a plan.
Yeah, kind of just take that, like our goal and something Anne's been really passionate about is creating kind of like a pathway all the way from outpatient to inpatient so that it's pretty consistent no matter where the patient's coming from. So that's kind of our hope.
Cool. Yeah, those are great goals. It sounds awesome. And I already actually, one of our expert faculty group members for this project is an OB at Stride, and we've already been talking, and she is going to loop in another doctor there and discuss this. So they're already probably a little bit aware, and at least one of them is interested in joining. So
that would be great because we get an awful lot of their patients that deliver here with us.
Cool. Yeah. Nick says in the chat, we will implement ACEs and participate with the collaborative with the new project. Cool, cool. Anyone else goals for increasing outpatient coordination? Oh, and by the way, I should mention, what Mick is talking about is that there is a new project happening in the Valley View area that is specifically focused on outpatient inpatient coordination that we are also running. So that is what she was referring to. Yes.
So this is Lisa Becker from PSL again. You know, and again, learning a lot about the whole sort of nature of the project. Earlier this year, I had put together packets of the resources that were valuable to me from CPCQC, and actually given, we only have 2 private OBGYN generalist groups that deliver at PSL. So, you know, it wasn't that many packets to deliver, fortunately not 100, but I did give an individual packet to each of those providers with an introductory letter and saying, you know, I'm very happy to learn with you. Please contact me if you have any questions. But I do think it's a much better idea to have somebody at each of those groups who's invested directly and not peripherally. So I will definitely reach out to those people. I actually also approached one of our nurse midwives who has done work about screening or substance use disorder on Native reservations. And she's a great asset. She's interested in being with us, and she has contacts in hospitals in other states. So that might also be a way to get more people involved in this project.
Absolutely. Yeah. And I should mention, you know, we're absolutely also expanding to new hospitals. And as some of you may know, we have 11 in 2021, our cohort is 11 Colorado hospitals, and we actually have 3 Montana hospitals. So teams from out of state are welcome to join. The more the merrier, really. Cool. Anyone else want to mention anything they hope to accomplish by working more closely with outpatient teams? That's question number 2, but it could be your goals. It could be question number 1, question number 2. I know they're sort of similar. Okay, well, I do want to move on to, I'll skip question 3 because obviously it's very individual to your team. But question 4 is, even if you have outpatient teams that opt to not join the collaborative, once they learn about it, they say, no, we're good. Are there other ways you can think of that you could better collaborate with them in 2022, specifically on these issues? So Lisa, we're definitely going to ask you to send us the packet you made, because we love that. You know, even if they don't join, they could at least, you know, see what we're doing, get some of those resources and information. But yeah, wonder what you all discussed for your answer to question 4.
Looks like Lisa said, just keep the communication going. I hope to have enough knowledge to answer their questions quickly and provide support.
Yeah, I think that sounds good. Yeah, I mean, I think, you know, of course, with some of what is a part of this collaborative anyway, in terms of SBIRT and what the brief intervention or referral to treatment could look like, you know, one of those things could be, and really should be, making sure that they have postpartum care set up. And that could, you know, you could make a warm introduction to a postpartum doc, or just make sure, you know, you give their outpatient clinic a heads up of what you found, what you're seeing. And hopefully, you know, if they have patients who they know are going to deliver to you, hopefully you do foster relationships so that you can say, hey, if you know ahead of time that this patient has substance use disorder, they have depression, they have anxiety, like, let's keep open communication so that we know that before they're in our door in labor, and can really care for them better. Okay. Well, I will move on to the next item. And that is talking about data for 2022. So we definitely heard your feedback about data cadence. Obviously, we know monthly is hard to do, especially in the midst of staffing shortages. So what we want to do is maintain a cadence where we're able to keep providing you sort of customized support and know what's going on with you, what your challenges are, what resources you might need, but also reduce the burden of, you know, collecting a lot of patient data that in some cases, you know, takes time to collect. So we want to talk to you about data in 2022. So what will be changing is that there will still be monthly data collection in REDCap. However, those monthly questions will not require you to collect any patient data. They will be the same questions that you're already answering at the end of the questionnaire every month. That is about, you know, what are your goals for the next 30 days, 60 days, 90 days? What challenges have you encountered? What support do you need? They'll just be reflection questions that hopefully we think you can answer pretty quickly. And just give us an idea of where you are so that we know what you need support with, what we might, you know, if you want to check in with us. So they'll be super short. So that will begin March 1st. So we kick off in February, that'll begin March 1st. But again, we're hoping it'll take you less than 10 minutes to complete that. It'll still be in REDCap. And then where the sort of bigger shift is in more of the quantitative data. So a couple of, so there'll be the questions that are basically the first part of what you're already submitting. So none of the reflection questions, more of the questions about, have you implemented this protocol? What are your screening rates, et cetera, et cetera. One trade-off we're making is we are going to have your submitters make a REDCap login for submitting this information. So right now you're able to just click the link and fill it out. And we love that for simplicity's sake, but we also have heard you about, you know, right now when you're having to say every single month, have you implemented a depression protocol? And you say, yes, it's fully implemented. And then it asks you when you implemented it. Once it's fully implemented, you don't need to be answering that question anymore. And we know there's been a lot of data quality issues because, and we don't blame you, but like, you're like, oh, well, I think it was fully implemented this month. So from month to month, we'll have people who say, this was fully implemented in September. And then the next month they'll say this was fully implemented in November. So there will be a login, but that will mean you won't have to answer questions every single month and your answers will save. So once you've fully implemented something, we will never ask you that question again, which hopefully will be better. The other big change is that AIM, so the Alliance for Innovation in Maternal Health, you know, this collaborative, the objective of it is to implement AIM's patient safety bundle for obstetric care for people with substance use disorder. So as part of that, you know, we participate in AIM or an AIM state. And what that allows us to do is both get resources from across the country and also from a data perspective, be able to compare ourselves to other hospitals and other states across the country. So AIM is coming out with new measures in 2022 for this bundle that we'll get into in a little bit. The benefit of this is we will be able to upload your hospital's data to AIM's National Data Center and be able to show you visualizations of how your hospital compares to other hospitals in the state in a de-identified way, and also to other hospitals in the country on your progress towards this patient safety bundle. So of course, the trade-offs are that there'll be a login and that there will be new data you'll have to enter, but we're hoping, you know, the beauty of this new data is that it'll focus more on what happens after there's a positive screen. This first year, we've really been focusing on like, let's just screen. So many of you are already doing such a great job of that we're ready to move on and talk about like, okay, what happens once that patient screens positive? So those measures will focus more on that, and I'll get into what the measures are in a second. I do want to point out for the timeline. So AIM data collection is only quarterly. And what that means is that you will not submit quantitative data to us until July, because you will be collecting April, May, and June data, and then you'll submit it in July. So we will be able to spend January, February, March preparing for data collection, helping you get a system set up so that this doesn't feel overwhelming. You can get the new measures. So I'm about to go into the new measures, but I say that because I don't want anyone to fret, because we have plenty of time to figure out and to really help you with being able to make sure you can get these measures so that we can submit them to AIM, so that we can show our progress. So that being said, the plan for 22 data measures, these new quantitative measures that I'll talk about that are due quarterly and that are from AIM, the main difference between last year's measures and this year's measures are that these new ones do make a differentiation between substance use disorder, SUD, and opioid use disorder, OUD. And you'll see why in a second, but this is actually a really helpful distinction because, for example, medication for opioid use disorder, so Suboxone, methadone, that is something that is not available to someone who, for example, has a substance use disorder involving methamphetamines. There are no treatments like that for methamphetamines. So you'll see in a second why the differentiation matters, but that is one thing. And then again, we'll really be focusing more on what happens after a positive screen. The next major thing is that teams will need to create a process to ensure that certain information is captured in the patient charts and will be able to be recorded. Again, we will spend between now and the end of March helping your team prep to be able to collect this data. And you won't have to actually submit that data until July 15th. But as you'll see, a lot of the data will be based on, okay, this patient screened positive, and then did all of these things happen once they screened positive? So part of your process will be making sure that in the notes for that patient, you're capturing those measures and able to report on them. It's going to seem overwhelming at first, but my big caveat that I want to tell you is that for most of you, your denominator of patients who screen positive for SUD is going to be so low anyway that this might seem overwhelming, but for most of your teams, it's actually not going to be that many charts that you'll have to look at. So the name of the game will really just be, let's create a process to review the charts, and let's also create a process to make sure that this information will be in the charts when we need it. But part of the reason also that the data is quarterly is, again, because these the denominators will be so low anyway. If we asked you on a month-to-month basis, your answers for these next questions might be 0 anyway. So it'll give us more time for you to actually get some positive screens to report on. So I'll go over these data measures pretty quickly. Again, I know it feels like a lot, but I promise we'll work on it together, and it's also going to be pretty low numbers. So basically what AIM wants to know And they want all the patient numerators disaggregated by race and ethnicity. So I'll say that now. Again, it won't be that many charts. They want to know of patients screened for SUD, how many screened positive. They want to know of patients screened for SUD, how many specifically screened as having an opioid use disorder. So let's say your SUD number is 10. For the number of patients who screen positive for SUD is 10 over 3 months. Your OUD patients would be part of that. So let's say 10 have SUD, of those 10, 5 have OUD. And so it would be 10 of SUD, 5 of OUD. And that will be that. And then the next measures are all about, again, what happens once the patient screens positive. So was the patient counseled on recovery treatment services? And we have definitions of what that means. And then did the patient receive or were they referred to recovery treatment services? So this is where, again, it's going to be really important that these things are captured in the charts. Next, were they counseled on naloxone prior to delivery discharge? And were they prescribed naloxone or did they receive naloxone prior to delivery discharge? And these are all for patients with an SUD diagnosis. And then next, for those with an OUD diagnosis specifically, were they counseled on medication for opioid use disorder? And did they receive or were they referred to medication for opioid use disorder? For many of you, you might be familiar with the term MAT, medication assisted treatment. That is what we're talking about here. MOUD is the term we use these days. Next is about substance exposed newborns. This is a balancing measure. And it will be, oh, I'm sorry, this row was supposed to be deleted. I did this, ignore the naloxone question. It is just % of newborns exposed to a substance in utero who go home to either birth parent. So that might involve coordination with your social worker / case manager and might involve coordination with NICU. And that's why. And then lastly, and this is a guesstimate, and AIM is very upfront about the fact that they know this is a flimsy measure. So don't stress out too much about how you'll answer it. But essentially they want to know the % of your L&D staff, so nurses and OB providers, that have completed education on care for pregnant or postpartum people with SUD. So that could just be attending our events. And the % of your staff who have completed education on respectful and equitable care. Again, that could just be attending our events. And they want guesstimates in increments of 10%. So you could say, oh, we have 10 people on our staff. 3 people have attended these in the last 2 years. So we're going to say 30%. And that'll be that. We won't have to stress about it too much. So we're going to go back to another worksheet, another breakout to think about all of this, because we know it's a lot. We know it can be overwhelming, but we promise it'll be digestible. So we are going to go back to the worksheet and answer the remaining questions. There are questions 5 through 8. And they are just about the quarterly quantitative data. As a reminder, if it helps to see the measures as you're going through these questions, they are included at the bottom where it says summary of 2022 data measures. It includes everything I just talked about. Again, ignore this. That was a mistake. And then the monthly qualitative measures I've included in here also, just if you needed a refresher on what those are. But really, because the new process will be around these new quantitative measures, you will be answering questions 5 through 8 about these, how you'll start to think about gathering this quantitative information. So we will put you back in your breakouts and go from there. Again, here is the file. If you didn't have it before, you can see it here and download it to your computer and write in there or not. But that's what we'll do next. We'll go back into breakouts for 10 minutes.
I think everyone's back now, Katie.
Awesome, thank you. So it's 2:26. I want to spend just 2 minutes recapping what you talked about with your team, and then we will close things out. If anyone could chime in about what you talked about in terms of ideas for how to start collecting this.
Hey Katie, it's Ann and Megan from university. We have a 2:30 meeting, so we're just gonna go first and kind of blast through.
Do it.
We've worked hard for the last year on creating a spreadsheet and a report for all of our data, and literally with all the people that are involved, it took almost a year to get it correct, but we feel finally that we have the right information flowing into the report that we can get. You can go ahead and chime in, Megan.
So our plan is to just be able to take that report, and then our team collects data of who we see, and then just kind of use that to hopefully compare and work with our data analysts to hopefully have just an easier way to pull the data of who we saw and then who we missed, and then just kind of follow up on the few that we missed.
Awesome.
So the amount of hand auditing that we have to do has went from 100% to very small amount. So
yeah. That's great. Well, yeah, that sounds like a great plan, and totally, I mean, this takes time, and so yeah, it's not necessarily going to happen overnight. Sometimes it'll take a year, but that's okay. Anyone else? Anyone like, oh my God, this is impossible. How am I going to do this? We want to hear that too, because we promise we'll help you. Okay. Well, we can move on to our closing slide, which is just some next steps that we are asking for by the end of the year. So we know that's coming up quickly. It's the 16th, so we have a couple weeks, but if you haven't already, please do complete this worksheet with your team. It'll be very helpful to start thinking about this stuff early. Second, start reaching out to your outpatient clinics to gauge interest and let us know how we can help. In the follow-up to this call, we'll definitely send you some materials you can share with them. You're welcome to CC us on emails with them if you want to like introduce the idea and CC us at your leisure. And we will do all we can to help you coordinate all of that. Again, begin to strategize that data collection piece and involve any necessary stakeholders now, like your IT team, social work, NICU, et cetera. And please reach out to us if we can help in any way. We anticipate having calls with hospitals that are just like, okay, let's figure out this data piece. So we're ready and willing for that. Have a happy holidays. The Learning Collaborative kicks off on February 10th. So you'll have all those dates in your emails soon, I'm sure, with registration and whatnot. The last thing we ask is if you could please take our evaluation poll real quick before leaving. Callie just launched it, so it should be somewhere on your screen. And please answer those questions before you go. We hope you have happy holidays. Even though we know a lot of you work on holidays, so it's weird to tell you that, but we hope you get some rest and relaxation and holiday magic at some point in the next couple weeks. You can sign off whenever you're done filling out the poll. If you have any questions for us, we'll be here for a minute or two. And yeah. Thanks, Lisa.
Gang's all here.
Okay.
You're funny, Elena.
Also, I laughed so hard when Nick said, "We'll make shit up."
We'll just make shit up. I was like, yes, that is me.
That is the high school energy we need.
Yeah. She is such an awesome person in person. I got to meet her at the A1 conference, and she's just like this ball of like fun energy.
That's awesome.
Cool. All right. We did it.
Yay, good job, ladies.
This is our last one of the year.
Woo!
Yay.
Now I get to go edit our wonderful conversations that we had prior to the start of
Oh, that's going to be joyful.
Oh,
I'm
God.
sure.